it's 7 o'clock. Welcome everyone to the First Five and Derbyshire Education Network session. We're so pleased that you've joined us tonight and given up some time to join us. And special thank you to Chris and Marge, and I will introduce them in a second. Firstly, we will go to Benisha in a minute. And just to say tonight, as I'm sure you know, is all about feeling confident with diabetes guidelines. So we've had lots of people sign up, and if they haven't managed to come on now, then they'll be able to get the recording. So if you do join a bit late, or if any of your colleagues join a bit late, don't worry, they can always see the recordings. And Benisha, can I hand over to you? Is that okay?
Yeah, brilliant. I'm just going to share my screen. There we go. So hi everybody, my name's Benisha. I think many of you probably already know who I am. I do these quite regularly. So I'm from Chiesi and I cover the Foster range across the Derbyshire area. So I'm just going to do a really quick reminder on our Foster range, especially our Foster Nextaler, and we're going to be talking a little bit about the benefits of Foster range for those patients that need stepping up from an ICS alone. We're going to talk a little bit about making the right device choice for the right patient, and especially in this time when we have a lot of different inhalers on the market, not making those unnecessary switches unless they're for a clinical benefit. And then we're going to just end on talking about some of the benefits of our dry powder inhaler, which is our Foster Nextaler. So the Foster range then comes in a dry powder inhaler and a PMDI. It's the only extra fine formulation that's available in 2 different devices and across a range of strengths. And obviously it's licensed for the regular treatment of your asthma adult patients where use of a combination inhaler is appropriate. So for example, when they're stopping up from an ICS or they're not controlled on their current treatment. So obviously I've spoken to you guys about this before, but your typical patient then is somebody like Chloe. So she's maybe reaching for that blue inhaler more than 3 times a week, and we know how much of an issue sort of overuse of SABA can be. So that's sort of the patient that I just want you to have in mind when you're through this talk. So maybe somebody who's coming with maybe an asthma attack or over reliance on their blue inhaler. Just have a think about what you'd be looking to do with that patient. So the Foster range can be a great option for patients like Chloe, because like I said at the start, it's available in 2 different devices. So that means you only have to remember sort of the one drug, but you can have a look at and see whether that patient is dry powder suitable or PMDI suitable and really make the decision based on what's best for that patient. You get fast and effective symptom relief within 1 to 3 minutes. So that's what allows it to be used in a MART regime, which again is a great regime to get patients off the blue inhalers because you can use it sort of up to 8 times a day. I'll go through the exact license for that in a second, but ultimately it's having that flexibility for your patient. So whether they're dry powder suitable or MDI, whatever fits their lifestyle, you have both options there. So I mentioned at the start that the Foster range is an extra fine formulation. The dry powder, the Nextaler, is the only extra fine dry powder inhaler on the market. So it has a very small particle size, which is what allows it to have better lung distribution. So 2/3 to the upper airways, 1/3 to the lower airways. And you can see on the left hand side there, they compare the particle sizes and they look at the optimum size, which is needed for that high lung deposition. So it's really important to consider when you're deciding what sort of inhaler to go for. I mentioned at the start, obviously, the formoterol as well. So that means it works within 1 to 3 minutes, and it allows it to be used in this MART regime. And all MART is giving the patients a window of opportunity to get some extra steroid in and prevent, how symptomatic that patient feels, in the days leading up to exacerbation. And that's what this graph shows. So in the Foster, then it's the same as the Nextaler or the MDI. It's the 100/6 that's licensed. You'd give it as once in the morning, once in the evening, which is a normal maintenance dose, and then allow them to use it up to 6 times through the day, as and when they'd feel like they'd be reaching for that blue inhaler. And all that means is that you're treating the underlying inflammation as well as opening up their airways, and then you'd give that for a maximum of 8 times a day. A great way to get patients off their blue inhalers and get a little bit more treatment in. So that was the MART regime. Now I'll just quickly go on to talk about the Foster Nextaler. So and not obviously, we know not one device suits all patients, and I know there's so many different inhalers out there, and you're always sort of being asked to make switches and make changes, but it's really important that we get that decision right. So whether you're using an MDO or dry powder inhaler, we want to be able to support your decision. So with the dry powder inhaler, then it's the Foster Nexthaler. You get 120 doses per inhaler. If anybody wants any placebos, any support materials, do drop your email addresses in the chat function. I'll pick them up and I can drop some off to you. The biggest difference with the Nexthaler then compared to some of the other inhalers out there is that you have an audible click. Now that click is different, is unique in a sense of it only clicks on when the patient has had 100% of the drug delivered. So they only need a flow rate of 35 litres per minute, which is relatively quite low. Once they hit that 35 litres per minute, they get all of the drug, and you'll hear the audible click, which means they can successfully take that inhaler. It's a great little device because you can just give them a placebo and get them to have a go in front of you and be confident that they can take the inhaler. So I'll show you how to use that now. So it's literally just open, get them to empty their lungs away from the inhaler, and then it's a deep, sharp breath in through the click, and then hold your breath for about 10 seconds. On my breath, once you close that dose counter goes down. Again, the click is quite unique because if I play with this, the counter doesn't move. Again, if I don't have enough sort of inspiratory flow, nothing happens. You won't be able to hear a clicking noise. So it's a really, really foolproof device. So just to summarize then, the Nexthaler is the only extra fine formulation in an ICS lab that's available in a dry powder. You've got that extra support through being able to use it in a MART regime because of the formoterol working within 1 to 3 minutes, and the Nexthaler is really optimized for that drug delivery and patient reassurance. If anyone has any questions or wants any more information, please do let me know and I'll try and follow up with you. But I will pass you over to Dr. Owen. Thank you so much.
Thank you very much. That's really, really helpful stuff. So thank you very much. Well, it's a lovely lot of people have arrived. Really good to see you all. My name is Chris Owen. I'm a GP in Ilkeston, and I also work as the clinical lead for diabetes for the Derby and Derbyshire ICB. So I'm going to share my screen with you, and hopefully, oops, there we go, share. Can you see that all right?
Yes, can see that great. Thank you, Chris.
That's lovely, excellent. So, as the name suggests, an overview of the new Derbyshire guidelines on the management of type 2 diabetes in adults. So these are the Derbyshire guidelines, but they are pretty identical to the NICE guidelines, which is exactly what you'd want, really. So here are the key messages. This is going to be an overview. They're about, 40 pages long, so obviously I won't do every word. But I just wanted to point out a few things. It talks about assessing a patient's cardiovascular status, and I'll come back to how we do that. That's really important in the new guidelines. And it's all about adopting an individualised approach. If you've got somebody with type 2 diabetes who's 25, it's obviously very different than if they're 95. So obviously you have to look at the patient in front of us and adapt to them. So one of the really big things in the new guidelines is assessing their cardiovascular disease status. And how they do that is you look at how old the patient is. If they're over 40, you roll a Q-risk score, as you always would, and if it's 10% or more, then that patient is at high cardiovascular risk. And I think we're all very familiar with that. The new thing is, what do you do if they're aged under 40? Because if they're only 25, they could have another 60 years ahead of them. And so we're looking at an elevated lifetime risk of cardiovascular disease. And we define that as the presence of one or more cardiovascular risk factor. I'm just going to ask a quick question. Part of my slides are being covered up by people. Is that the same for you, Elise, or is that only on my screen?
I think that's only on your screen. I can see your complete slides at the bottom, but I can see as chronic kidney disease.
That's lovely. That's great. Just want to check I wasn't covering up for all of you. So we've got over 40, we look at their Q risk, and if it's over 10%, they're at high risk. Under 40, we look at have they got one or more cardiovascular risk factors. So that would count if they've got hypertension, raised lipids, they smoke, or they're obese, or they've got a family history in a first-degree relative of early cardiovascular disease. Now, when you think of the people that you look after with type 2 diabetes, almost everybody over 40, if you run a Q risk, it shows it's over 10%. And if you think back to the people you look after, how many of your patients under 40 have perfect blood pressure, perfect lipids, and they're skinny as a rake? Very, very few. So that will be most other people. But if any haven't been caught by this, the other two searches, then it would really be if they've got chronic kidney disease of an ACR of over 2.5, or if they've got a GFR that's deteriorating. The other thing that I'll be saying as we go through is about offer and consider. So NICE and Derbyshire defined offer an intervention that's going to do more good than harm and be cost effective for the vast majority of patients. So really, if it says offer, you really should be doing it unless there's a good reason not to, or the patient doesn't want it. And then consider is an intervention that does more good than harm for most patients and will probably be cost effective, but other options might be similarly cost effective. Most of the talk tonight is on all the different drugs for HbA1c, but I just wanted to say first, point out really, you can't beat dietary advice, can you? That's where you've got to start, unless the patient's doing their bit. All the drugs in the world aren't going to sort it. So dietary advice is really important, physical activity, really important. Bariatric surgery can be important for some of our patients with a BMI of over 35. But blood pressure and lipids, there's a link on both of these, and I can send the slides to Elise and Co. And so if you want to then have them, you can then click on those links. But this is all on the Medicines Management website. So yeah, can't stress enough, HbA1c is only one part of diabetes management, and blood pressure management and lipid management are incredibly important. So just to show how important it is, I just wanted you to imagine that you've been looking after 1,000 people for the last 5 years with type 2 diabetes. Well, I don't have to imagine it too hard, nor does Suzanne, our practice nurse who's on the call. We have been looking after 1,000 people with type 2 diabetes for the last 5 years. In fact, we've now gained an extra 300 as a bonus. And if you can unmute, if you're feeling brave. So we've got these 1,000 patients with type 2 diabetes, and we've managed to reduce their HbA1c by 10, which would be pretty good going for all of those 1,000 people. And we'd have prevented 8 cardiovascular events. So I want you to imagine now, supposing we'd reduced their cholesterol by 1 millimole on average. Have a guess, shout out a number. How many cardiovascular events might we have prevented? Less than 8, more than 8?
Oh, Chris, I'll say maybe more, maybe 20.
Maybe 20.
Lisa said
yes.
The same.
yeah, there's another 20 to go. Very good indeed. So yeah, we'd have prevented 23 major cardiovascular events, strokes, heart attacks, cardiovascular deaths, pretty unpleasant things. Brilliant. And supposing we reduce their blood pressure by 10/5, any idea how many cardiovascular events we might have prevented? Any numbers in the chat there?
Oh, Lisa said 40.
40, wow.
Oh, very good. Yeah, she knew higher. 20. Yeah, that's brilliant.
yeah, it's definitely higher. So actually, I just wanted to put this in to say, yeah, it's really important to work on HbA1c, and obviously that really helps preserve people's kidneys and eyesight and prevent neuropathy. But let's not forget how important cholesterol is and blood pressure, and what enormous good we can do by focusing on them as well. So without further ado, this is a very busy slide, but I'll talk you through it and we'll concentrate on the highlighted yellow bits so you can see where we're going. I just wanted to point out at the top, a new concept in the NICE guidelines is rescue therapy, and I'll come back to that in detail. But this is what you do when someone's got really high sugars and they need treatment right now, and it suggests using insulin or a sulfonylurea. And then what do you use as first-line treatment? So on the left-hand side, it says what to do if people have got chronic kidney disease, and you can click on the link there. But I'm going to focus the next box along on what do you do if they're not a high CVD risk. So this is almost no patients in Derbyshire, but someone who's incredibly young, incredibly skinny, with perfect blood pressure and lipids, you would offer metformin. And if they've got any gut disturbance, you then go for generic metformin modified release. The next box along is what if they've got congestive heart failure or established atherosclerotic CVD, by which we mean people with strokes, heart attacks, angina and peripheral vascular disease. So in that position, again, you'd offer metformin and MR if needed. And then this is the key thing, and as soon as metformin tolerability is confirmed, offer, remember that's a really strong word, an SGLT2 inhibitor with proven cardiovascular benefits. So these really do reduce your risk of heart attack, strokes, etc. And our preferred one in Derbyshire is EMPA, but you've also got dapagliflozin. Notice it doesn't say offer metformin, wait 3 months, see what the HbA1c is like, and if the HbA1c is high, then offer an SGLT2. It just says, wait till you know they're okay on the metformin, and then add it in. So you might want to start metformin and increasing by say 1 a week, and then book them an appointment for 4 weeks to see how they've got on, and then offer them the EMPA then. And now the third box along is these people with high risk of CVD. Remember, that's all the people over 40 with a Q risk over 10%, or the people under 40 who've got hypertension or raised lipids or obesity. So nearly everybody. Again, it's offer metformin, and as soon as metformin tolerability is confirmed, consider an SGLT2 then. So even if the HbA1c is good, you would still consider it because there's so much cardioprotection with that. And then where do you go next? So if you've agreed a target of HbA1c with your patient and you haven't quite reached it, what would you add in as second line? So it's saying here you can consider a sulfonylurea like glycoside, you can consider a gliptin like anagliptin, IO, or an SGLT2 inhibitor if you haven't already added it. But actually, for most people, that's going to be second line, unless there's a good reason not to. And then at the bottom, you've got the GLP-1s, particularly if they've got a BMI of over 35, adjusted down if they're from a BAME ethnic group, or if they're under 35 and there'd be significant occupational problems with insulin. So, which SGLT2 inhibitor should you use? So this gives you the traffic light status. Empagliflozin is green, dapagliflozin is green, canagliflozin is grey because there is a possibility in some patients of an increased amputation rate, and you don't really want that. And ertugliflozin is grey because there's not quite as much evidence for the cardiovascular protection for the two. Now, there's been a bit of confusion in Derbyshire about, well, which one should you use? When do you use it? So I summarised this in 3 sentences, and I thought, oh, this is far too simple. I bet it's much more nuanced than this. So I sent my 3 sentences to my favourite diabetes consultants and said, is this right? Can I say this? Or is it much more tricky than this? And they all replied to go, yeah, no, that's perfect. That's exactly what you need to know. So here we go. Which SGLT2 inhibitor should you use? And the question is, what is the primary aim of prescribing the SGLT2 inhibitor? Is it to reduce HbA1c, in which case you go for empagliflozin? Is it to protect the kidneys? Then use dapagliflozin. Is it to improve heart failure? You can use EMPA or dapagliflozin. The reason for that is, so EMPA has been our first line for a long time, and we're very much used to it. And the cardiovascular protection is possibly even better than DAPA. The reason we're saying for DAPA for the kidneys is that at the moment it's only DAPA that's licensed for renal protection. There is the evidence there for EMPA, and it probably will be licensed in the future, but it isn't yet. And I don't know about you, if there's 2 drugs and one is licensed and one isn't licensed for an indication, I generally go for the licensed one. So those are the 3 real reasons we would be using an SGLT2. So just a word of caution, yes, they are brilliant. As you probably know, the patient wheezes out loads of glucose and they lose weight and their sugars come down and their blood pressure comes down and even their gout gets better and cardiovascular protection, the whole poodle. But we do need to be cautious. If the patient's got significant osmotic symptoms, so they're losing weight, they're drinking all the time, weeing all the time, then obviously could it be type 1? And you absolutely don't want to be giving them an SGLT2 and tip them into ketoacidosis. Be really cautious if they're on one of these really low carb diets, one of these sort of Atkins diets, In actual fact, I had a friend of mine, I was walking around the park with her, she was on EMPA, she decided to buy herself a ketone meter, having read about ketosis on the internet. And she was on an incredibly low carb diet, like 20 grams of carbs a day. And she said, oh, Chris, sometimes my ketones go up to 3.5. Should I worry? I'm like, oh my goodness. Here I am in the middle of the park with you. Yes, you should worry. We really don't want ketones above 0.6. So yeah, people need to be on maybe 100 grams of carbs a day. Otherwise, it pushes in ketosis. I personally wouldn't start it at an HbA1c of 86 or higher, and I'll tell you in a bit what I would do. That's not a hard cut off. If you're more bold than me, feel free. There is a higher risk of inducing DKA if they're at a very high HbA1c and you suddenly bring it down, because these are really effective. I also wouldn't start it if the patient was on insulin and had started the insulin within a year of diagnosis, because maybe it wasn't type 2, maybe it was a type 1 or a LADA. So any concern whatsoever about type 1, check a blood ketone and ask urgent advice. Definitely don't prescribe an SGLT2 inhibitor would then precipitate DKA, and always cancel regarding the sick day rules. So put simply, if the patient's got a fever or they could get dehydrated because they've got diarrhea and vomiting, stop it until they feel better. Before I go on to metformin, are there any questions in the chat? I don't know if I can look at the chat while sharing. Elise, are there any chat questions regarding anything I've already said that might be worth covering now?
No, there aren't any questions in the chat, but anyone, feel free to unmute if you have got a question. But yeah, that was really interesting. Thank you.
Oh, pleasure. So yeah, any questions you've got, feel free to ask as we go along or at the end. So moving on to metformin, we all know about metformin. Just a few quick things. It's no longer, if people don't tolerate it and we want to try modified release, it's cheaper to prescribe it as generic modified release, not Staccato. Another key change is the maximum dose is now 2 grams per day rather than 3 grams per day. So if anybody, when you're doing an annual review, you spot, or you're seeing them for any reason, if you spot there are more than 2 grams per day, I would definitely ask them to reduce that to 2 grams a day. Partly because it says at the bottom, there is this bigger worry of metformin with reducing B12 absorption, and the higher you go on metformin, the more likely you are to cause a low B12. And the MHRA, about a year ago, produced a guideline. Here we go. And there are a lot of people were asking on our diabetes WhatsApp chat, which I'll tell you about later. They were saying, well, what do we do? What do we do? This is a massive job. Can you imagine checking all the B12s on everybody with metformin? And what happens if loads of them need metformin? I mean, it could have created utter chaos in practices and all across Derbyshire. So in collaboration with some of our consultants, I produced this guideline, which is basically, number one, definitely keep to a maximum recommended dose of 2 grams per day. Number two, every patient presenting with a symptom of B12 deficiency needs a B12 test. So this could be neuropathy. And the tricky thing with diabetes is, of course, if they've got tingling in their feet or their fingers, our first thought is, oh, it's the diabetes causing it. But I would also put them in for a B12 test as well to check that that isn't causing it or at least making it worse. The rarest symptom I've never seen, but some of you may have done, is glossitis, a painful swollen tongue, and that's another indication for doing a B12 test. Or if they've got a macrocytic anemia, so low hemoglobin with a raised MCV. So that's worth checking. Now, interestingly, number three is that what the guidelines say is that a low B12 on metformin is likely to have lots of different causes, to be multifactorial. Hence, they say rather than stopping the metformin, instead they advise you to replace the B12. And the last one is, it says consider checking B12 on every patient on metformin, but it is considered rather than definite. So if practices want to do that, they can, but there's no sort of obligation to. I mean, the other option, put at the bottom, you can start saying, well, we'll do people who've been on metformin for ages, or if they're vegan or from a PPI, but that becomes, I think, more and more complicated.
Chris, can I just ask,
so moving on to GLP-1s. Yes.
Sorry, Chris, I just wanted to ask, did you do any testing in your practice? Did you?
So we are a big practice. We've now got 1,300 people with diabetes. And I just thought, oh my goodness, if they all start needing, 6B12 initiation injections, this is going to cause absolute chaos. And at the moment, I think a lot of practices are under huge strain already. I didn't want to tip us over the edge. So we haven't, what I do if I spot somebody who's on more than 2 grams, I do actually do B12 level at that point. I reduce them to 2 grams, and I say there's a risk that you could be low on vitamin B12, and let's do a test. But I haven't gone looking for all of them because I just think it might sink us.
Yeah, that makes a lot of sense. Thank you.
Yes. That's a pleasure. That's a good question. So GLP-1s. So for ages I've been wanting my favourite 3 to be green, and finally they are. We've got liraglutide is green as our first line GLP-1. We've got lixisenatide is still green, but the manufacturers have stopped making the 10 micrograms of starting dose. I think the manufacturers realise that actually, compared to all the other really good GLP-1s, who's going to choose a GLP-1 which doesn't help you lose much weight, it doesn't help bring your sugars down by much, and it doesn't have any cardiovascular protection? So to be honest, they're on their way out, really, lixisenatide. So the main ones are liraglutide, which is a daily GLP-1 injection. Then we've got Trulicity, which is a weekly GLP-1 injection. We've got Ozempic, which is also weekly GLP-1 injection. Now, Ozempic is the generic is semaglutide, and that comes in the weekly injection, Ozempic, but it also comes in a daily oral preparation called Rybelsus. And the real key there is if prescribing Rybelsus, the patient needs to know that they need to be able to swallow it with a tiny bit of water and absolutely no other drinks, food, fluid, tablets, anything for half an hour, which is really important. Otherwise, it just won't work. So the good news is all these lovely, wonderful, really effective, superb GLP-1s are now green. The bad news is the whole world has run out of them. So basically, there's such low long-term insufficient stock problems of both Ozempic and Trulicity that even the manufacturers, even the drug reps are approaching us and say, please don't prescribe my drug, which I've never come across before. So the hope is if we don't start new patients, then the current patients who are on Ozempic and Trulicity can carry on, but actually even then we're struggling for supply sometimes. But new patients, if you've got a new patient who needs a GLP-1, you can start them on Victoza or liraglutide each day, and that is currently reasonably in stock. But the trouble is, of course, we're all starting lots of Victoza, so who knows what will happen to that. There's no stock problems with oral Ozempic, the Rybelsus. It's great, and it is available for patients with needle phobia or who really don't want a daily GLP-1. That's an option. So, if you remember right back at the beginning, on the Derbyshire and NICE guidelines, it talks about rescue therapy, using gliclazide as a rescue treatment, particularly if the patient's symptomatic with their type 2 diabetes, and particularly if their HbA1c is over 85. So I want you to imagine for a moment, you're working through your links, and you come across somebody with an HbA1c of, say, 90. And I want you to think about, well, what would your thoughts be? So if 3 months ago their HbA1c was 110, you'd be like, oh, that's great, it's got down to 90 already. I can see them in a few weeks and we can consolidate the good work and get it down by further. You're not going to be worried, are you? But what happens if that patient's got a new diagnosis of diabetes, so brand new diabetes, or you look at the HCA has done their weight and it's 5 kilograms less than it was last time, or if someone's documented they're thirsty or weighing lots, all the HbA1c has jumped up by more than 30. Any office, if you want to unmute, what would you do with that patient PathLink result? What would you do?
Does this include intentional weight loss?
No, sorry, this unintentional weight loss. Thank you, Julie. Yes, if it's unintentional weight loss or it's brand new diabetes, what would you do when you see that PathLink? You can be brave, folks. Would you invite them in? You would, wouldn't you? You'd basically want to be picking up the phone and getting them in that day and checking them over. And doing a blood ketone, I would really, really recommend that every single practice in Derbyshire owns a blood ketone meter and blood ketone strips. And we can talk later if you want on which is the recommended one and how to order them. But it's really useful because it basically sorts out the really poorly people from the people you don't need to worry about. So I want you to imagine if that patient's got blood ketones of 1.5 or over, or it's 0.6 to 1.4, but they look unwell, they feel unwell, that obs are dodgy. What would you do? You'd admit them, wouldn't you, really? And actually, you know, sometimes we get a bit of grief trying to admit people. You don't get grief if their ketones are over 1.5. They'll take them straight in. And but then what do we do if the patient's got ketones under 0.6, their blood ketones, and they're stable? So this is what we'd suggest you do. Basically prescribe glycoside 80 milligrams once daily with one of them reasonably big meals. Actually, breakfast is often one of the biggest carb meals for many patients. But yeah, so glycoside once daily, and also get them going on metformin if they're not already on metformin. You can start at 500 milligrams a day. I would also give them a blood glucose meter and show them how to use it, give them the testing strips, give them the Lancets, and say to them, please check your blood glucose every day before breakfast and before your evening meal until I next see you. And the only exception to that would be if they're really frail. So I had a 92-year-old with an HbA1c of about 110. And actually I went in on 40 milligrams of glycoside. In the end, she needed 160 BD and then we needed insulin. But I thought, let's do it slowly, step by step. So if they're frail, I would only give them 40 milligrams of glycoside, and I'd only do it if they were really thirsty or their HbA1c is over 100. And then I'd book a follow-up appointment for a week or two with either myself or one of our diabetes nurses, and safety net to say, please phone me if your blood sugars are under 4 or you get unwell with vomiting.
Sorry, Chris, can I just ask something on that?
Please do.
And that's really interesting because I've had a couple of people, similar cases to this in the last few months. I didn't start glycoside and metformin at the same time. Is that what you're suggesting? Because I just started metformin to start with.
Okay. So people often only start metformin, but actually, if their HbA1c is about 85 or they're really, really symptomatic, then actually it's going to take a long while with metformin to get anywhere. So I have to confess, I was only starting glycoside, but when I ran these guidelines past some consultants, they were like, to be honest, I'd get them on metformin as well to get that going. So yeah, with both together, you're going to see some progress quickly. Yeah, that's a really helpful question.
Thank you. Thanks.
That's a pleasure. So what would you do at the first follow-up appointment? If the blood glucose readings are still high, so if they're mainly over 12 or in a frail person, they're mainly over 15, I'm going to move on because I think audience participation is maybe not our strong point tonight. I'll give you the answers. So if the blood glucose levels are still really, really high after a week or two, I'd go up to glycoside twice a day, perhaps with breakfast and evening meal, or if they're frail, I'd go to 40 twice a day. If the blood glucose reading's already improving, or you think, this is not bad, you then just titrate the metformin to 500 milligrams twice a day and keep the glycoside at 80 for now. I would then definitely book a follow-up appointment with one of our very good diabetes practice nurses to discuss all about, just to make sure they know what they're doing with lifestyle, an ongoing review, and then gradually try and get that metformin up to 2 grams a day if it's needed and tolerated. And then once the blood glucose readings are mostly under 12, we really want to be weaning down the glycoside and thinking about something that will actually help them lose weight, because most of our people with type 2 diabetes are struggling with their weight. Not all, but most. And actually, empagliflozin has got so many more advantages for them than glycoside has. But going back to what I was saying before, I wouldn't want to go straight in on EMPA if they've got a really high HbA1c, because I wouldn't want to precipitate DKA. So get them stable on the glycoside and then you can introduce the EMPA. You can either wait 3 months if you want and do an HbA1c, or my feeling is once the blood glucose readings are mostly under 12, you've got an HbA1c that's equivalent to under 85. And you can start to introduce EMPA, wean down the glycoside, and hopefully get them off it. I see glycoside, it's rescue treatment. It's a bit like you're throwing them a life ring when they're drowning in the middle of a lake. It's a temporary thing. Actually, you want to, once they've been rescued, get them on something better long term. And I put it at the bottom, just a reminder not to start EMPA if you've got a really high HbA1c of 85 or lots of blood sugars over 12. So just to conclude this little bit, all 3 treatment targets matter, not just HbA1c. Lifestyle is key at every consultation. I spoke to a lady this week who I discovered a year ago was drinking 12 litres of full sugar Coke a day. I mean, I don't know how you get that much liquid in your body, but she was, and bless her, she'd had a lot of abuse and all sorts of traumas all through her life. And this was her way of self-harming. She knew she shouldn't, but that was her way of self-harming. And actually, with it wasn't even well enough to cope with counselling, so we referred her to our chaplains in our practice, and then she's had counselling, and she's done really well, and she is completely off the Coke. Well, if I hadn't have discovered that and talked to her about how are you doing, and her telling us about that, you know, we could have wasted millions of pounds and millions of consultations on trying to investigate tablets, whereas actually what she needed was the support and the to get her off the 12 litres of full sugar Coke. And then consider mental health. 40% of people with diabetes have diabetes distress. So 10% have a proper clinical diagnosis of anxiety or depression. 40% have diabetes distress where it's not like a clinical illness that needs tablets, but they're just really fed up with their diabetes. It's causing them distress. It's just relentless, isn't it? Type 1 is relentless, type 2 is relentless, and you've got the stigma in the media and so forth. And they just really need a supportive listening ear. They might benefit from counselling, but often just you listening and supporting them is what we need. But stop medication that's not working or is sitting in the cupboard. They're probably the least effective, least cost effective, certainly. Don't forget to individualise the target with the patient in front of you, individualise the medications appropriate to the patient in front of you, and individualise the approach. Now, I've got some case studies, but I think I'm going to stop sharing there because I'm quite excited to introduce Marge to you. Marge is, well, and you can start screen sharing if you like, Marge. So Marge is doing a GP fellowship for the year and has put a lot of time and effort into looking through all of the wonderful resources you can find anywhere on the internet that you can use, and also how to make the best of Ardens. Apologies to any practices that don't have Ardens, but this is a quick whip through for any of you that do have Ardens on how to make the most of it, and Pathfinder. Without further ado, over to Marge.
Thank you very much, Chris, for a great presentation. My name is Dr. Whittaker. I'm one of the salaried doctors from Bloomington Surgery. I just want to show you today a quick overview of the resources and useful templates which I found on Ardens. There seems to be so much information, and just to know which one to actually pick up, I thought I've done quite many hours, days, I would say, going through them. Hopefully that you don't have to do it. And then you can decide which one you think you could use in your daily practice. Can you see my screen clearly?
Yeah, that's showing nicely.
Lovely. So I just want to show you, I will start like that and ask if you ever seen maybe this lovely diabetes care plan, which I just found accidentally initially. And this made me actually trying to find some other useful resources patients have. This plan actually, after 5 clicks, within 5 seconds, it's usually come up on your screen about every patient. So it will be in the name, will be saying what complication diabetes they have, which is automatically pulled from the screen, from the information which are already on system 1. All annual check which patient had done, HbA1c, when it was, blood pressure, cholesterol, ISO. I think it's a lovely plan, which you can even print, give the patients, because it's all showing what for 1 year we've been doing for these patients. And at the bottom is written actually even the results, test results, which are important, HbA1c, what was previous one, where they are now, and where we want them to be. So it seems to be like a clear way to show the patient, oh yes, you are doing brilliant, look, you've been there, now you are here, you are on the target, brilliant, or you went a little bit off with this, like blood pressure needs a little bit tightening, or the other one. In this plan, you would be able to write what you want with patient, what you agree today. So together. So for example, exercise more, eat healthy, anything, and then you can print and give the patient home. And this is like 1 yearly lovely review. I don't know if any.
How did you get to the care plan? Sorry.
Yes, and now I will be showing you. I just wanted your interest, thinking if you think that it would be useful for you guys. So I will make it smaller. When you are on your patient, now some of us you will have, or already have or will have in the future Pathfinder, which is, or you press F12, or like our manager done, Launcher straight away, or you can have D click on your screen. We have Launcher, or you will have D diabetes. And then when you press on it, if you have, what I've done, I put actually on this side, which I like, because if you put diabetes on this side, try and search for it, look how much information comes actually. And do you really have time to go through all of them and finding what is useful with diabetes? Yes, I've done this. So I thought hopefully you only need these 3. So one of them is diabetes long-term condition review. If you click on it, but then it comes with initial review and test. When you click it, usually diabetes here will be highlighted. There is some glitch in my system in this tester only that actually I need to go to old version, but with every other patient it's working. I clicked on long-term condition review, initial test, diabetes is lovely highlighted. And then when you press on diabetes, not only you can put here new target values, what you want for a patient, but you can forget about this because this is not what you wanted. You wanted care plan. By pressing just this number, this care plan, it's opening right now and is starting opening this care plan. It's already everything before, so you don't need to yet have the patient. You can print it before. Takes a few seconds, sorry, to open it. That's why I had that ready, and it's here open. Can you see it? That's it. Should I show this once again, how I got to it?
Yes, please.
What I will do after this presentation, I actually will be sending all information to Elise, who will be sending you how to get to this point. So F12 click to all of you, unless some of you have Launcher or the icon. In the search box, you can put long-term condition review and press search. In the search coming 2 different ones. Legacy, it was just last month they removed, well, they said still they will have it for 1 year, but it's exactly the same like new, because there is this glitch in the program. You just press new. What you can do, you can drag it by pressing left side of the mouse to this side, and then you will have forever on this side. Anything from here, you can just drag it to the other side and always will be staying there. So next time when you are opening any patient with diabetes, you don't have to write it, it's already there. When you press inside long-term condition review, but with you will be written new, then you press at the top is initial review and test. It's straight away highlighted diabetes when patient has diabetes. You press diabetes and then you press this care plan, and care plan is opening. All of information there, HbA1c, cholesterol, everything is auto-populated. You didn't have to put anything. It is all what system is actually taking from the notes of the patients. And then you can print the patient and straight away start explaining where you are, where you've been. Does it make sense? Any questions so far?
That's lovely, thank you.
And this is, I've spoken actually with Ardens, if they can do it, that it will be together with one of the other icons. So hopefully it will not be 3 icons that you can use. It will be just diabetes review and diabetes pathfinder, that's it. But they are working on it. The other, when you are actually with patients, especially when you are doing this 1-year review, diabetes review, so you again, on the search box, you are putting diabetes review. When first time you do this, it takes longer because you haven't done this before. Because I've done this before, I already dragged it here. So I already found it and moved it here. I'm not sure why it doesn't want to do it now. When you double click on it, sorry, once again. It's opening lovely, a lot of possibilities. So in home is just general information about the patient. If you press diagnosis, it's telling you when you can decide patient has diagnosis type 1. All criteria are here. Diagnosis type 2, criteria here. Very often on WhatsApp was question about pancreatic cancer. When to think patients have pancreatic cancer. When you press, it's coming when it's less than 40 years old or 40, 60 years old. If you press it, it's telling you criteria. For now, it's saying unlikely to be cancer, criteria not met. But if you go through criteria, is telling possible cancer. I will cancel this template. Then what is gestational diabetes, pre-diabetes. So you don't have to remember things. Everything is written there. Also, sometimes we want conversion. Conversion of the millimole to percentage is also there. Another is review assessment. In a review assessment, you can find BM diary and then print for a patient so they can put their blood sugar if they don't have other. Target values, you can put what you want for a patient, so later it will come up with a care plan. Again, you have conversion here if you wish to use it. You have also their BMA calculator, so you can just say, this is where you are, this is where we want you. And next one is review plan. So when you explain them, you can just put control, diabetes is good control, lifestyle advice on diet, alcohol, smoking given. You just tick boxes. When you've done this a few times, instead of just writing all the time the same when you are doing diabetes review, you just tick what you told the patient. What is there very good is diabetes formulary. They are medication, like Chris was mentioning, which one to use. And again, is divided, not at high risk CVD or high risk, which one to use, metformin and the rest. You can prescribe medication from here already. So you go check which one you want to prescribe. You want to prescribe metformin, you press metformin straight away. You want, for example, this course to be 500 milligrams 1 week, then increase. It's checking for you creatinine, you just proceed and prescribe for a patient. Don't proceed, proceed. And it's prescribed. It's also here written sick day rules. When you press here, that sick day rules given, and one of them is lovely sick day rules. Let me just move this one, which you can just print to the patient and give at the same time. You can go all of the medication, including SGLT2 inhibitors. You don't have to think about GFR. It's mentioning here when to use, avoid if GFR is 30, 60, avoid, and different GFRs. Also, there is leaflet about sick day rules. I will just cancel for now. In the same, there's so much information in this Ardens, which depending what you want to give to the patient, tell the patient what leaflet you want, everything seems to be here in one place. When you are here, you can give some well-being information, mental health resources. You can write patient goals, and when you write them, that they will later come on the care plan. You can take care of cardiovascular disease, think about the statins, when ezetimibe to use. Prescribe also from here, any of those. So this one is quite long one, and at the end is also care plan. However, this care plan, when you press care plan at the bottom, it seems to be a little bit longer. So I actually personally prefer the other one. This one looks very similar to start with. There will be written advice, agreed action, what are the goals, which you already wrote before, what are current medication. And there's slightly different explanation where they are, maybe more detailed. HbA1c, blood pressure, BMI, kidneys. You can decide whichever plan you prefer to give them or choose to be clearer for you. Any questions so far? Oh.
I think
It's a lot.
There's a lovely comment. Maybe I need to get out more, but I'm really excited about using this to its full potential.
I think it's just, if you imagine that you have like 15 patients per day and you every time writing lifestyle advice and all of this, and then you can just tick boxes that you've just done. And then you can show actually patient with this one first page, I thought, where they've been, where they are now, so they know exactly what was discussed. And, you know, it could be 2 quick advices: exercise more, eat less or more healthier, and that's it. And then you can show, this is what you discussed last year, this is where you are now. So actually you didn't do much better despite you thought, because clearly numbers doesn't lie. There is another information about like hypoglycemic event. You can just mention here that he had or didn't. It's just like telling you what to ask the patients to not forget. There are leaflets, what is hypoglycemia? So again, instead of thinking and trying to find on Google, you just print Trend UK and it will come leaflet, which you can give patient at that point if they have hypo. Information the same about the driving is already there. You advise them that they are on insulin. They need to notify DVLA. it's a lot when you do first few patients, and then you think, oh, tick, 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 tick boxes, and it's like prompting you what to ask them, making sure you didn't forget anything. So even there is about hypo awareness score you can do. I don't know if any of you have been doing. I will just go straight away to the to not have to wait. How it looks like, I think it's this one. Awareness of hypoglycemia. Question which to ask, responses, and then you can even give the patient. So it looks like you don't have awareness of your hypoglycemia event. Again, key care is just reminding you which 9 key care we went through, but on this first page already, which I showed initially, care plan is everything mentioned there. There are also some online resources which you could send to patient, like questionnaire, if you wanted, before they are coming for appointment, which is, have you attended structured education program? Have you had any hypoglycemic attacks? A lot of information, so it would be admin probably. Last one, you can go through any of them, but I just thought some of you, it's just so much to look. It's just probably having 1 hour to go through and decide what is needed for your practice, what you would benefit from. Here I can see, sorry, let me just unmute. Here is also a lot of resources at the end, the diabetes, dementia, patient information, what to do when you are ill and you have diabetes. So you can just go straight away just there and give them any leaflets about hypoglycemia, hyperglycemia. There are also those prescription sheets regarding blood pressure. If you want quick one, just 1 page to give to the patient about blood pressure, cholesterol, lifestyle advice, any of those. And then you can just print for them. So I would say from diabetes review, it's main one what I would use. And I would just remind once again, for me, it would be just going diabetes review, and it's opening straight away. Diagnosis, assessment, review plans, hypo, hyper. It's so quick to go now, once you've done this once. Any questions so far? And there will be one more. I would explain you.
Marge, there's a question about what if you're on EMIS. Now, Ardens you can have whether you're on EMIS or System 1, can't you, if your practice or PCN's paid for it. Am I right?
I believe so, but I've never worked on EMIS, and I'm not actually specializing. I'm not trained on, on Ardens where it's going, but I was told in the past that in both of them could be, but I haven't checked personally. So it's just somebody, if you have EMIS, please go tomorrow. I will send this information, how to get to them once again. So you can actually, it's like really, really simple how to go 1, 2, 3, 4 clicks, and you can check if you can get it exactly the same.
Now, thank you, Marge. I think if you're happy to stop screen sharing, we can look at some of the questions together, if that's okay with folks.
Yes.
So there is also, we haven't gone through it today, but also on F12 is, I'm afraid it is only for System 1 practices at the moment, is Diabetes Pathfinder. I've tried to put on there everything you might ever need to know about diabetes in Derbyshire. If I've missed off anything and there's anything that would be really helpful, then please let me know. I'll put my email in the chat. But just looking at some of the questions that have come up, a really good one from Julie is oral Ozempic only grey because of the cost. I asked that same question, but actually, if we were allowed to give if we could start new patients on the injectable Ozempic, if there were enough stock, actually the injectable does have a much greater weight loss and significantly greater weight loss and HbA1c lowering. So that is ideally better than the oral Ozempic, but actually it's not in stock. People are answering questions. Please, can you go over how to get the ketone meters? So at the moment, it's Glucomen, Ario, and CareSense Dual are the 2 who are the recommended ones from Derbyshire, and any of I could send the information to Elise if that'd be helpful on how to contact the reps and how to have their phone number and then send off for one of those rep meters. You're probably better to go for CareSense Dual because Glucomen Ario 2K is being phased out over the next year and there's going to be a new one replaced, so you don't really want to get yourself a meter and it go out of date that quickly. So yeah, I'll give you the CareSense, find out the CareSense Dual info for you. That's a good thank you from Benedicta. When would you aim to come off the glycoside afterwards? So yeah, really be looking at the blood sugars, obviously really reinforcing lifestyle. And actually when all the blood sugars are doing pretty well, I would introduce EMPA and either cut it out completely or step back. So hopefully within the first month or two really, but it just stabilises people enough that you can then start your EMPA safely. Yes, how did you get to that screen? I think you've shown us again. Elise will help us to send out everything Marja's done. Marja's written out for us as well, so we can follow it. And yeah, you can find it in ARNZ without Pathfinder. Thank you. Yes, you can also get to the care plans through Ardens just by pressing on the D or diabetes review. It is exciting. Totally agree with Sorelli about that. Yeah, it is on EMIS. And yeah, thank you, Lisa. Likewise, Accurix is amazing, isn't it? If you've got that or a similar system, to be able to copy and paste things, you know. So I just put the word hypo in, and it has a text all about hypos. I put in 6-day rules, and it does that. Yeah, I've got a text for every eventuality to send people, and it is brilliant. Yeah, and Marge has just replied, F12, you can do diabetes review and long-term conditions review. Rachel's put, are the glycoside rescue guidelines on F12 or can I access elsewhere, as I don't seem to be able to get F12 on the laptop? So what I can do, thank you Rachel, that's a really sensible question. I am not sure. I will, if they're not on Pathfinder, I will request that they go on Pathfinder. I'll take that as an action. And I'm also happy to send them to Elise to circulate to you all. So that takes us to 2 minutes left. If anybody wants to ask any questions out loud, you're welcome, or to put them in the chat. Also, I'm going to send to Elise the details of the diabetes WhatsApp group. A couple of years ago, I was invited to join it, and I thought, oh, that's really exciting. So I did, and it was 20 really keen nurses. I said, I'd love to be part of your group. Anyway, over the last 2 years, we've now hit 250 people in Derbyshire who are working in primary care and got an interest in diabetes. Oh, I know it's on the WhatsApp chain. There's a lot on there. That's true. So I will get that on Pathfinder. But I really like the group. People just ask a question when they're stuck. What do I do about X or Y or Z? Sometimes questions that you won't ever find the answer on the internet, and it's just kind of what do you do in real life kind of questions. And what's lovely is lots of people answer. Sometimes people ask really complicated pharmacy type questions, and there's some really good pharmacists on the group who answer them. And I post stuff. Health Education Derbyshire post stuff about new guidelines and new education stuff. I'd really recommend Health Education Derbyshire's website. If you go on the training events and then click on diabetes, you get some really good events to go to. And again, I'll ask Elise to circulate that. It's going to be a chunky email, Elise, I think. Any questions?
It's been really, really informative. Just the way you've just made it, you and Marja made it so succinct and so useful and so applicable to all of us. It's just, I think, yeah, everyone's just putting loads of thank you messages. I think it's literally just been exactly the right level. So thank you so much. Thank you for your time and putting the presentations together.